Okay, we're going to go ahead and I'm going to go ahead and lecture on chapter 23, which covers neurocognitive disorders. Again, we're going to begin with this case study, which is going to lead up to give a clinical overview of a client with delirium, or she may have dementia. So we're going to just see as we walk through the clinical picture. This is a woman brings her mother to the clinic. She's concerned that her 85-year-old mom may have dementia. I'm Ellen, she says when you enter. This is my mother, Veronica. She's not much of a talker these days, so I've come with her to help her express a few things that we both are a bit worried about. Right now, Ellen says, you're pretty sure she has either delirium um, or dementia, maybe what's the difference between the two. So we're going to look at the difference between delirium and dementia. The clinical picture again for delirium, these clients, they have a problem or disturbance in their attention. They also have some disorganized speech or thinking, I'm sorry. They may become disoriented, have some anxiety issues. They may also have poor recall, hallucinate, usually delusional or hallucination, but usually it's visual instead of auditory. Um, they shift their attention all the day back and forth. They may be anxious. They may be some other characteristics. Like I said, they may be agitated, poor memory. Again, they may have that delusional thinking. So, with that being said, um, as far as the epidemiology, again, usually you see it in the elderly population, your frail elderly. Usually it can also happen with those clients that are critically ill. It could be due to a change in their health condition or physiological reason as well. Sometimes we put clients, they're admitted, the elderly population, they're admitted to the hospital and they get confused, get disoriented. So they may become delirious as a result of the unfamiliar environment. Some other factors of physiological causes could be infection, sleep deprivation, dehydration. Certain medication can cause physiological manifestation. Again, these clients will have impairment with their vision and their hearing. Most of the clients they are immobile. They become immobile. Again, that's a safety issue for these clients. They're risk for falls, things of that sort. With the hearing and vision, the vision rather, put them also at risk for injury falls. Um, Ellen continues. She said, "Well, it's mostly a problem with memory that started maybe 2 years ago, one and a half, maybe. This daughter really doesn't really know exactly when it occurred. So you asked, did something abrupt set this off? No, Ellen says, Mom, do you think some events may have triggered all of this? Veronica shakes her head. So does she have outbreaks of lucidity? You ask, not really. Ellen shakes her head. She pretty much say the same thing all the time. So she doesn't change um, her story. She's pretty consistent with what she's saying. So we can look at that question. So as we look at this client, we're looking at her overall health, doing an overall assessment. We're assessing her cognitive or perception disturbances. Make sure her physical needs. She again, if they become confused, disoriented, they usually have self neglect. They don't eat. Um, they don't bathe. Their personal needs are unmet. And also, we're gonna assess their moods and their physical behaviors. As far as an assessment, again, we're going to be using the DSM-5 criteria. And again, we were looking at any disturbance in their attention. Also, like now, this again, delirium can be very abrupt. It can be due to, like I said, infection. It could be due to a medication or unfamiliar environment also. So as far as when we're assessing the clients, again, do not assume confusion is dementia in the older client. Just because a client comes in demented, or they may be confused and disoriented, it may not be dementia. Rather, it could be again going back to common, things that we see a lot, urinary tract infection. Uh, We want to look at any fluctuation with this acute onset, or can that a client again tend to their own immediate environmental needs. Um, or establish whether or not there is a disturbance in their cognition, looking at their physiological status. Is it due to their diabetes or the UTIs I mentioned? To assess all of their vitals, do a neurological assessment on this client. Are they at risk for injury or for potential injury or injury? Again, assess for availability of any immediate medical intervention to help prevent brain damage. So we know if we don't treat that UTI, that it can lead to sepsis, which can lead to brain death. Again, it can become systemic. So we got to make sure. Monitor any situational factors that worsen or improve symptoms. Is their situation? Is the client? It should be the elderly. They are at risk for abuse or hypertension, or they are being abused. So these are some of the nursing diagnoses, not all inclusive. As you can see, a risk for injury. It's kind of like at the top of the list, but it could be something else due to your when you collect your data. So these are a list of nursing diagnoses that could be applicable. So again, we want these clients when we do our assessment, gather our collect all our information, develop the care plan. We want to make sure that this client is safe, free from injury, any falls. Make sure that when we talk to these clients, we want to orientate them. Also, they may have to have aids, something that a hearing aid or glasses to help them, with their activities or reading or whatever. So again, fluid balances and adequate nutrition may be maintained. Again, these clients, like I said, they may become dementia, have delirium. They forget to eat or they won't eat. We want them to be comfortable. Also, make sure that whatever supportive device that they're using, they are safe to use. And again, like I said, visual cues in the environment for orientation, showing them pictures, things of that sort. Make sure they follow up with their providers for continuity of care. Implementation, again, you see, we're going to prevent from harm, monitor electrolytes imbalance, may have to use minimum restraints if they get really confused. But again, remember the little restraints protocol. Make sure you use your agency protocol. Again, assist with identification and the treatment and the cause of what's the problem. What is this confuse or delirium or confusion linked to? Okay, then we're going to evaluate the client, make sure that our goals or outcomes are met. Um, we're going to talk about some major and some minor neurocognitive disorders, which as we look at these clients again, they may progress from mild to major. So the goal is to decrease or prevent the progression. We do not want these clients to progress, get worse. So again, we're going to orientate them again, the problem solving method, uh, assess their ADL because usually when if it's mild, it usually does not interfere with their ADL. It does not necessarily progress if it's mild. However, if these clients with intellect or dementia, it could deteriorate. It could get worse, progress. And when it gets to major, it interferes with daily function and the client's independence. So again, we're trying to prevent progression or deterioration of cognitive function. As we look at the evidence, we're using that DSM-5 manual also. So Ellen describes Veronica's problem further. She has trouble remembering things like where she put the electric bill. I, I helped her find it and thought that was that. But then the next week I picked her up for lunch date and she looked really nice, no problem with that. She always ready to go, but her house was freezing. I said, Mom, did you pay your electric bill? She stared at me. So guess what? She forgot to pay her electric bill. So that's one sign right there, forgetfulness, misplacing stuff. As the disease, these are some major neurocognitive disorders here. So when it become major, again, it gets progressively getting worse. So Alzheimer's is one of an example of one of your major disorders here. It is the most common, Alzheimer's is the most common cause of dementia. Okay. It's very devastating disease because, like I said, it's burdensome on the caregivers, it's burdensome on the family. And so it's very taxing for the family to take care of their loved one. So it can progress, get very, like I said, it may be mild, moderate, then it could get severe. Again, with Alzheimer's, it is detected on CT scans, MRIs, identifying Lewy bodies in the brain. So it's a Lewy body disease. So with that being said, again, Parkinson's disease may be some of the clinical signs you may see also. Traumatic brain injuries and cerebral vascular accident. These are some major. Um, the most important thing here when we're looking at the clients with Alzheimer's disease, let's look at some of the clinical picture. Like I said, we got to make sure we determine whether or not there's a problem with forgetfulness or a memory deficit because it's important because those clients with that are demented, they can, like I said, it can lead to Alzheimer's. So in those clients with dementia, like I said, memory loss interferes with their ADL specifically. And as it progresses, like I said, they go through the acute phase, the mild phase, the moderate, and then the severe phase. And in mild, like I said, they may just difficulty retrieving or remembering names. Also, they forget material things that they just needed. They misplaced something, and then as it get to moderate, they could these clients um, could have a problem with their sleeping pattern. They have insomnia. They're going to be at a high risk for wandering. Also, they become compulsive sometimes and agitated. They repetitively do things like wringing their hands and things of that sort. And then as it gets in the late stage or the severe stage, these clients again they require full-time one-on-one. Uh, they are they become very fragile. They have problem eating, swallowing, so they become malnourished. So these clients end up they do come in a become in a be in a vegetative state. They may also have at the point they can't eat, they may end up with feeding tubes. Uh, and again, also some other symptom that you may see with these clients, they may, other than the memory impairment, they may have aphasia, have problem, loss of language ability, apraxia. They have loss of purposeful movement, and then agnosia, loss of sensory ability to recognize objects. Okay, so again, as it gets worse, it can, like I said, it can progress to a very debilitating disease. So again, a big problem here is memory impairment with these clients. You see it both common in late onset in females. It could be genetic um, a factor. It also could be due to cardiovascular disease. It could be due to head injury and trauma as well. Some things that we can modify, some things that we can do, modify the risk factors. We can help these clients with sleep. They need to change the sleeping pattern. The exercise would be a modification. Also, diet, social engagement. These clients, they do well if someone is sitting and eating with them, kind of coaching them. Education and mental stimulus also would be very beneficial for these clients. Um, so, with that being said, um, as we do our assessment on these clients, we collect all of our data. These clients, we pay attention to confabulation. Sometimes they affabulate a story, they repeat phrases, or sometimes they or go have long gestures. They talk for on and on and on. And again, they like I said, they may have problem reading or writing. Tendency to put everything in their mouth, hyperorality. And then again, I've already talked about these other issues in the prior slide. Sundown, then in sundown syndrome, tendency for mood to drop or an agitation to rise as the light of the day diminish. So as just like I said, late in the afternoon, sundown, they may have that sundown um, those syndromes or symptoms. Again, we're assessing for their memory, any disturbance in their executive function. Can they problem solve? Can they plan? Can they organize? Are they abstract thinkers? So this is a time when some family member needs to take control of their finances, pay the bills. Again, because of the fact, as we look at Miss Victoria, her light bill, her power was cut off because she forgot to pay her light bill. And as we do some diagnostic tests, of course, your CT scan, your PET scan will be tests that could be used to um, evaluate these clients or to help assist with the diagnosis. And then the mental status state examination tool, which is a many questionnaire. And also, of course, we're going to do physical exam, neuro assessment. And we're also going to be completing a medical and a psychiatric history on these clients. We're looking at their medication, their symptoms, and then again, their nutritional status. So again, we're gonna go through. We're gonna do, evaluate them, look at all the medications, see if they're a drug-drug interaction issue. Make sure they have all the resources they need. Their medication. Make sure that someone may have to proctor their medicine, do pill planners for them. Are they able to get to the healthcare provider to, keep up with their appointments? Okay, teaching and guiding about the sundown regarding sundowning. Again, they get real confused as the night time comes. And this is sometime when they start getting agitated. And then again, they have a tendency to wander off. So we have to make sure set realistic goals for these clients. May need stress management counseling. Again, realistic outcomes. Then we want to make sure that these clients maintain good self-care. So Ellen continues, but then the next week I picked her up for a lunch date and she looked really nice, no problem with that. So she was ready to go. But again, um, but her house was freezing again. I said, Mom, did you pay your electric bill? She blinked her eye. I don't know, she said. Well, okay, I said, let's see. Where's your checkbook? I don't know, she said. Just stop asking questions. I thought she was, going to cry. So that was she was getting agitated and aggravated because the daughter kept asking her questions. So what sign can we attribute that to? So we're gonna look at that. Also, these are some of your nursing diagnoses. Again, impaired sleep, self-care deficit, caregiver stress and role strain, anticipatory grief. So again, this is the time when the caregiver gets stressed out. There's a program that I'm accustomed to when I worked in home health. It was a respite program and an unskilled respite. Unskilled respite was a program that provided time for the caregiver to go leave the home, go shopping to take care of some of their needs. So there are a lot of resources out there because sometimes if the caregivers get stressed out, then there's been some instances where the caregivers were stressed and they became agitated. So you see a lot of abuse and neglect because the caregivers get to the point where they just can't take it anymore. Okay, so again, I've talked about the support for the caregivers. This again, we want to refer to the community resources, know what resources are available in the community. And I've kind of hit on this already. There are daycare centers out there, Meals on Wheels, adult daycare centers, Meals on Wheels, and I talked about the respite, help, hotlines, home health. Again, will be some other services. These clients, there are some treatment modalities. Do you have a medication for cognitive symptoms? Cholinesterase inhibitors, Alexon patches. This has been a drug that you may see on the TV a lot. Namenda, it's another drug. It's an antagonist. There are also some drugs that could help with the behavior symptoms, them from moods and agitation. Your antipsychotics. Um, some of them are high risk drugs with extreme. If we're going to use them, we use them as the last resort. These antipsychotics because um, they are the risks are very high, particularly in your elderly population. And then some integrative therapy like omega-3 fatty acid also may be used. But again, as we talk about medication, as we prescribe or the healthcare prescribe, we have to make sure we look at the drug-drug interaction, look at the adverse effects of these medications, and determine whether or not it's going to be beneficial or too risky for this population. Um, then you As I've kind of talked about some of the resources, so you can go back and look at the slide. I mentioned transportation, Meals on Wheel, hotline. So these would be some of your appropriate community resources. And again, like I said, that respite care. So as we plan care for this client, she's diagnosed with Alzheimer's. Uh, what are some next steps that you as a nurse could help with as both the patient and the family to adjust to the new diagnosis? So again, we can again provide education, provide support. Like I said, know your community resources. These will be some things that we can help the caregiver because again, like I said, it's a big strain on the caregiver as well. As I talked about those cholinesterase inhibitors, again, um, what they do to inhibit acetylcholinesterase also by increasing available acetylcholine. So again, they can be used for mild, moderate, and severe Alzheimer's disease. Now, some of the side effects of those cholinesterase inhibitors would be things like nausea, diarrhea, insomnia, muscle cramps, fatigue, anorexia. Going back to those side effects, so when we talk about nausea, vomiting, fatigue, nausea, vomiting, these kinds are going to be a risk for dehydration. So you want to look at those drugs from that perspective. Okay? Alexalon was another one that I talked about, could be used for mild to moderate. Again, you see the same side effects here. They probably have problem with nausea, vomit, and anorexia. So again, going back, looking at nutritional status, looking at assessing those clients for dehydration. Also, if they are dehydrated, they're going to be at risk for fall. So this is how you want to tie in, the link, the adverse or side effects of the medication, putting the client at risk. Also tying it into the disease. Okay. And then I talked about Namenda. Also, Namenda it decreases excitatory neurotoxicity. So again, it's used for mild to moderate as well. These clients they may complain of dizziness, they may have headaches, and also confusion and constipation. So if the constipation is out of the medication a side effect, then we need to make sure we assess the client's bowel. They just document when the last time they had a bowel movement. So again, you're doing a thorough assessment on this client. Let's see. Okay, so I think that ends the discussion. So I've talked about dementia, delirium, and Alzheimer's again, and some of the causes, or some of the underlying causes or factors that could risk factors or biological factors. As I said, we talk most of these disorders we talked about they're genetic in nature. Okay,